சார் டாக்டர் வெங்கடேஸ்வரன் சார் வந்திருக்கீங்களா சார்?
இன்னும் ஜாயின் பண்ணலாம் மேம் அவரு.
ஓகே. ஸ்பீக்கர் இன்னும் வரல சார்.
ஓகே மேடம், வெயிட் ஃபார் ஹிம் மேடம்.
5 minutes.
சீனு சார்.
சார்.
நம்ம மேம் கிட்ட சொல்லிட்டு
ம்
நம்ம மூணு பேரும் நீங்க மேடம் சார் சரண் சார் கேட்டுட்டேன். நம்மளுக்குள்ள ஒரு கெட் டுகெதர் வச்சு பிளான் ஃபார் த இயர். நம்ம இந்த வருஷம் என்னென்ன பண்ணணும் அப்படின்னு முதல்ல பிளான் பண்ணீங்க. இந்த சரண் சார் பிஸி ஆயிடுவாரு இப்போ எலெக்ஷன்ல. ஸோ அவரையும் கன்சல்ட் பண்ணிட்டு அவருக்கு தகுந்த மாதிரி டேட் நம்ம ஃபிக்ஸ் பண்ணிட்டு வாட் ஆர் த ப்ரோக்ராம்ஸ் டு பி டன் ஃபார் திஸ் 1 year. அதே மாதிரி என்னென்ன வாட் ஆர் த சர்வீஸ் ஆக்டிவிட்டிஸ் டு பி டன் அது நம்ம பார்த்துக்கணும். பிளட் டொனேஷன் கேம்ப்ல சரண் சார் ரொம்ப பெரிய அளவுல பண்ணார் பர்த்டேக்கெல்லாம். ஸோ அந்த மாதிரி வரும்போது நம்ம அந்த வாய்ப்பை பயன்படுத்திக்கணும். நம்மளுக்குள்ள உட்காந்து ஒரு நாள் பேசலாம் ரூம்ல.
சரி சார், கண்டிப்பா சார்.
ஆமா, நம்ம இடத்துலயோ இல்ல ஜெயா ஹாஸ்பிட்டலோ உட்காந்து கூட நம்மளோட டிஸ்கஸ் பண்ணிட்டோம்னா ஃபார் திஸ் இயர் என்னென்ன சர்வீஸ், என்னென்ன சிஎம்வி, எப்போ பண்ணணும், இடம் இதெல்லாம் பிளான் பண்ணி முதல்ல வச்சுக்கணும்னு வச்சுக்கோங்க. கோ ஃபார் த ஆக்டிவிட்டி.
சரி சார், கண்டிப்பா சார்.
Speaker. The speaker sir has joined, sir.
I have joined, madam. I'm Dr. Krishna.
Good evening, sir. Welcome, sir.
Thank you, madam.
Thank you. Shall we start, sir?
Yes, madam.
Shall we start, sir?
Yes, madam.
Okay, sir.
Secretary sir, telling madam.
Yeah, okay, sir. Yes, sir.
Start பண்ணலாமா, sir?
Madam.
Good evening, friends, senior and junior doctors, and our speaker, Dr. Krishna Chaitanya. Welcome to our virtual CME, and this CME is our 6th in the series, and the second for the year 2021. Shall we start our program with Tamil Thai Valthu by our esteemed past secretary, Dr. Parmeshan, sir. Thank you, sir, for joining us. Sir, over to you, sir.
ராணிப்பேட்டை ஐஎம்ஏ தலைவர், செயலாளர், பொருளாளர் உட்பட அனைத்து உறுப்பினர்களுக்கும் மாலை வணக்கம். தமிழ் தாய் வாழ்த்து. நீராறும் கடலுடுத்த நிலமடந்த கெழிலொழுகும் சீராறும் வதனமென திகழ்பரத கண்டம் இதில் தெக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகம் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே உன் சீரிலமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே நன்றி.
Thank you very much, sir. Now, IMA prayer by Dr. Venkateshwaran. He is there. Dr. Venkateshwaran, sir, are you there, sir?
Yes, sir. Yes, ma'am.
Sir?
Madam, join, madam.
Thank you, sir. Thank you. Dr. Venkateshwaran is our orthopedician from Valaja Government Headquarters Hospital. Sir, lead us in IMA prayer, sir.
Yes, ma'am. Good evening, everyone. In the IMA prayer. Any meeting of IMA shall start with IMA prayer. followed by physician's prayer and the flag salutation. One of the office bearers should lead the prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you.
Thank you very much, sir. Now
ma'am.
our physician prayer by Dr. Srinivasan, sir, our finance secretary.
Yeah, good evening to all. I welcome you one and all. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, one pray. I give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of burden of my suffering fellow men, and true realization of a rare privilege that is mine. Take from my heart all will and worldliness, with the simple faith of child on rely on thee. Thank you.
Thank you, sir. Now our flag salutation by Dr. Shanti from Bell Hospital. Madam, please. Dr. Shanti, madam. Hello, Dr. Shanti.
Ma'am, good evening. Good evening to everyone. Is it audible, ma'am?
Yes, madam.
Yes, ma'am. Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind. Long live IMA. Thank you.
Thank you, madam.
Thank you.
Now over to the welcome address. Good evening, doctors. On behalf of office bearers and members of IMA RANIPET branch, I extend my warm welcome to each one of you doctors who are attending this online CME, sparing your valuable time on a Sunday evening. And I take great pleasure to extend my hearty welcome to our speaker for the day, Dr. Krishna Chaitanya from Narui Hospitals, who has accepted our invitation to speak with a very short notice. Thank you, sir. We are honored by your presence and eagerly looking forward to a lively, interactive and informative session. Thank you, sir. And I extend my warm welcome to our past secretary, Dr. Parmeshan, sir, who has made his presence lively by his melodious Tamil Thai Valtu. I extend my warm welcome to our honorary secretary, Dr. Saravanan, sir, and to our finance secretary, Dr. Srinivasan, and all our office bearers. And I also extend my warm welcome to all doctors who are making this special presence for us eCME and have spared time in spite of the busy Sunday schedule. And I'm happy to share that this is our second CME, eCME for this year. And hopefully we should be able to start with physical meetings in a couple of months. By then, most of us would have completed at least 4 weeks after our second dose of the COVID vaccine. And by then, the COVID situation also would have eased out, hopefully. And I request the support of all our IMA members to continue our monthly CME, either virtual or live. And we plan to conduct regular blood donation camps, either monthly or once in 2 months, and we need your support for the same. And young doctors can also come forward to donate blood for a good cause. And Dr. Kirti, our Vice President, is giving us a lot of support for blood donation camps. And our next agenda for the month of March will be to organize some event for the International Women's Day, which is 7th of March, but we can conduct the program before the end of the March. And I need your valuable suggestions and cooperation. Hope our Women's Wing Secretary, Dr. Usha Nindini, and other senior doctors will come out with a nice idea. And once again, I welcome and thank each one of you for your presence here. And now our Honorary Secretary, Dr. Saravanan, sir, will give his secretary report. Sir, please.
Good evening, ma'am. It's audible, ma'am? Yeah.
Yes, sir.
Good evening, one and all. On behalf of RANIPET IMA, I welcome you all for the second online CME on diagnosing renal dysfunction by Dr. Chaitanya from Naruvi Hospitals. The report, as a secretary, I have taken as a secretary last month. So last month, in our IMA, we conducted online office bearer installation and also CME on COVID vaccine update and Urogyn oncology by Dr. Raghavan, Apollo Cancer Institute. And also last week it conducted blood donation camp at Ram Brothers with the help of the government Valaja headquarters hospital. Actually, it was very nicely conducted by Valaja headquarters medical officers. I think totally around 60 to 70 units were given to Valaja headquarters hospitals. So, as I told in the last CME, we have a schedule for all, for the entire year, we have all 4 Sundays for the CME in our IMA RANIPET branch. So, in future, as ma'am told, this we'll have a live online CME will be conducted by the IMA RANIPET branch. As ma'am told in the Women's Doctors Association meeting also, actually, we can ask Dr. Ushanandi ma'am to give inputs, and also my suggestion, like in Women's Doctors Association, we can give some cancer screening, like for the in a rural population, and to detect any early cancer this thing also. This is my suggestion. And once again, I welcome all the members of the IMA for his online CMA, and also welcome Dr. Satyana Krishna for your in a busy schedule to give a good lecture on it. We hope we will be enjoying your lecture, sir. Thank you.
Thank you, sir. Now our Finance Secretary, Dr. Srinivasan, will give his report. Dr. Srinivasan, please.
Yes, ma'am. Good evening to one and all. In the last month, as a Finance Secretary, I would like to report that we have collected 12,000 rupees of yearly subscription charges, and we have initiated for our IMA branch registration at Societies Act through one of our audited, Mr. Sarathi from Arcad. And PAN card also, we have applied a new one. So hopefully we'll get it in the next month. Maybe in the March end, we'll get our registration certificate and the PAN card also. And regarding the annual subscription charges, I request all the members to mostly pay through the online, through NEFT transfer or Google Pay if you have any. So that would be very convenient for all of us. And some of the members requested to collect in person through any members or through any person. So we are trying on that. After that, that is the final thing. And for the blood donation camp, we have spent around 2,500 rupees for the dates. We have procured and give it to all the donors in the Ram Brothers. So that is a spending which has happened in the last month. Thank you all. Thank you for the cooperation.
Thank you, Doctor. And now it's time for our long-awaited CME. And the topic is Diagnosing Renal Dysfunction by Dr. Krishna Chaitanya of Naruvi Hospitals. Let me say a few words about him. Dr. Krishna Chaitanya, he did his UG at Narayana Medical College, Nellore, and his DNB Internal Medicine from Railway Hospital, Chennai, then DNB Nephrology from Apollo Hospitals, Chennai, and he has worked as a physician at CMC Vellore Hospital and also at Narayani Hospital, Vellore. And he's currently working as a consultant in nephrology at Naruvi Hospital, Vellore. And he has done his dissertation in HIV and in membranous nephropathy. And his area of interest are critical care nephrology and renal transplantation. And let's brush up our basic knowledge on nephrology and be interactive at the end of the session and try to gain more knowledge, because CMEs are actually CPDs. That is continuing professional development. Over to you, sir. Dr. Krishna Chaitanya, welcome, sir.
Thank you very much for the kind introduction, madam. Thank you very much, IMA RANIPET, for giving me this opportunity to talk in front of you, even though it's a virtual meet. I'll be sharing my screen, madam. Okay. So today, the topic I've chosen for presentation is diagnosing renal dysfunction. Basically, this talk I intend to lay down the approach how to go about when we encounter any person with the renal dysfunction in the OPD or IPD basis. So initially we'll look at the definitions and then go about the evaluation part. Definition, chronic kidney disease. So what is chronic kidney disease? Chronic kidney disease is defined as abnormalities of kidney structure or function present for more than 3 months with implication on health. So the chronic kidney disease is, this is the definition given by KDIGO. So what is KDIGO? KDIGO is kidney disease improving global outcomes. It's a non-profit organization, mainly valuable organization, which provides us guidelines and definitions meant for providing health care for the patients with kidney diseases. So when we see the definition here, it's 2 parts. Any structure or functional abnormalities of the kidneys for more than 3 months, which is manifested by kidney damage with or without decreased GFR as defined by pathologic abnormalities which are detected by renal biopsy or which have markers of kidney damage, which include urinary abnormalities like proteinuria or microhematuria or even macrohematuria. Blood abnormalities like in renal tubular acidosis, where we have underlying renal tubular syndromes, or there is underlying tubulopathies, wherein we have hypokalemia or hypomagnesemia or hypercalciuria, or any imaging abnormalities which could be congenital defects or which have evolved over time, or if a patient has undergone renal transplantation. Even without all these things, with a GFR of less than 60 ml per minute, with or without kidney damage. So all these are included under chronic kidney disease. Further, they have further classified it into 5 stages: stage 1, 2, 3A, B, 4, and 5. Wherein stage 1 is normal GFR or a high GFR, and stage 2 is GFR between 60 to 89 mils. Stage 3 is 45 to 59 mils. Stage 3A, stage 3B is 30 to 44 mils. Stage 4, 15 to 29, and stage 5, less than 15. Here, if we see, along with the staging as per the GFR, there is also importance in the amount of proteinuria. They have noticed that the amount of proteinuria, the more the amount of proteinuria, more it's likely to lead a person to ESRD. So depending on the stages G1 to G5 and stages of proteinuria A1 to A3, the lesser the glomerular filtration rate and associated more proteinuria, higher the chances of any person progressing to end-stage renal disease. The next would be the definition of acute kidney injury. The acute kidney injury definition has evolved over time. Initially, it was the rifle classification, then came the Akin, and then the KDIGO currently. So the rifle mainly included risk, injury, failure, loss, and end stage. It was being practiced initially, then came the Akin, and current KDIGO, the acute kidney injury staging is based on the serum creatinine and urine output. Increase in serum creatinine more than 0.3 milligram per deciliter within 48 hours or more than 50% within 7 days is considered acute kidney injury when the serum creatinine is considered, or if the urine output is less than 0.5 ml per kg per hour for more than 6 hours. So if either of them are satisfied, then a particular person is supposed to have acute kidney injury, which is divided into 3 stages: stage 1, 2, and 3. Stage 1, as I mentioned earlier, stage 2, creatinine more than 2 to 2.9 times, or the urine output less than 0.5 ml per kg per hour for 12 to 24 hours, or stage 3, wherein creatinine is more than 3 times, or creatinine more than 4 milligram per deciliter, or initiation of renal replacement therapy, or anuria for more than 12 hours. So next, when we initially see some person with renal dysfunction in the OPD, it is always important to note down the history, because history is paramount. So when we see the person initially, it is important to identify whether the presentation is that of an acute kidney injury or the person already has a chronic kidney disease. Because any person with an acute kidney injury, if the insult is real, if we diagnose the insult and the insult is taken away and appropriate therapy is given, more likely that the person will improve. So we have to note the previous renal functions, urine routine or ultrasound of the kidneys, which might help us in diagnosing whether it's an acute kidney injury or a chronic disease. If suppose a person comes with a deteriorated renal function with an elevated creatinine, and if the particular person had a normal renal functions, which was done probably 2 or 3 months prior, it would indicate an acute kidney injury. Or if the person has a raised renal functions, which was there even prior, then most likely he has an underlying chronic kidney disease. Then the family history also plays an importance, because in some cases, not most of the cases, it could be a genetically mediated kidney disease, which has shown in the current person. If the particular elevated the renal dysfunction is thought to be acute kidney injury, then the event that led to the acute kidney injury would be important. We have to look for the event. Most of the time, it could be drugs like NSAIDs or nephrotoxic antibiotics like gentamicin or toramycin, either of garamycin. All of these things can cause tubular injury, as well as any contrast injury, which was contrast administration, which was given recently, that could also lead to acute kidney injury. If the event can be identified and appropriate therapy is given, probably there is a chance that they might revert back to normal. So when we notice the word renal dysfunction, most of us associate it with creatinine. So why is creatinine important? What is creatinine? When we see, the creatinine is not much related to the kidney, in the sense it is not produced by kidney. So what is it produced by? The creatinine is a 113 Dalton end product of muscle catabolism. It is derived by metabolism of phosphocreatine in the muscle, as well as from dietary meat intake or creatine supplements. So when the creatine is not secreted by the kidney, why are we measuring creatinine why are we taking marker creatinine as a measurement for renal dysfunction or renal function? So if you notice, creatinine is excreted by the kidney, but it is not absorbed or metabolized. In a steady state, the amount of creatinine produced by the body will be the amount of creatinine excreted by the kidney. So the creatinine tends to remain normal in any person in steady state, that is, in patient is in good health and not in disease. So creatinine is taken as a marker, and glomerular filtration rate is calculated by the creatinine clearance, which is calculated by collecting the 24 hours urine and estimating the amount of creatinine in the urine as well as the serum creatinine. So in any person, to calculate the function of the kidney using this formula, that is collecting 24 hours urine and then estimating the creatinine in the urine as well as the serum creatinine, would be cumbersome. So they have come up with various formulas wherein indirectly GFR, that is called a measured GFR. If you notice, when we calculate the GFR from creatinine, is called mGFR, not the estimated GFR. So the measured GFR is calculated by using various formulas, most of which what we will be using in the OPD will be Cockcroft-Gold formula or MDRD or the EPI equation. So EPI is the current equation which is being used. They are, to an extent, they give a appropriate measurement of the GFR, which would be useful in estimating the renal function. So other than creatinine, are there markers which will help us in estimating the glomerular filtration rate? Just like how I have mentioned, creatinine is a marker. There are other markers like urea and cystatin C. So if we see creatinine is produced from the muscle mass, it can vary as per the dietary protein intake. And a person with a higher muscle mass will have a higher creatinine. and a person with a lower muscle mass will have a lower creatinine. Creatinine will be lower in women and lower in elderly. Whereas if we see the other molecule, cystatin C, it is not dependent on the muscle mass and it is produced constantly by the all the nucleated cells. It is also likely to, it's also changed by the hypothyroid state or with the steroid use, and it is slightly lower in elderly person and women. Whereas there is other marker which we concurrently measure along with serum creatinine. When we have a person with renal dysfunction, we measure the blood urea as well as serum creatinine. When you see the blood urea, it also varies. It's also an organic molecular product of protein metabolism, but the variation of blood urea is much more difficult to serum creatinine. Blood urea increases with increased dietary protein intake or increased catabolism, infection, any internal bleeding, like in GI bleed, it increases, and in dehydrated state, the blood urea also goes up. We are all aware of that. So out of these three molecules, creatinine, cystatin C, and urea, creatinine is a relatively better molecule than urea, but cystatin C is a better molecule of all the three in measuring the GFR. But why do we measure creatinine? That is, a simple reason is because it is easily available and it is cost effective. We are not aware of many labs which do cystatin C. I am not aware. CMC does cystatin C only for research purposes. Creatinine is a cheap alternative by which we can measure the GFR. So a little bit about the functioning of the kidney. So we know what are the functions of the kidney. When we consider, when we ask a layman what does a kidney does, he tells it produces urine. But we all know it is not just that. So it is mainly useful in maintenance of homeostasis by excretion of waste products of metabolism, whatever we have read through now, and by specifically adjusting the urinary excretion of water and electrolytes to match net intake and endogenous production. So the renal blood flow is about 1.2 ml per minute. It's about 1/5 of the cardiac output, and the glomerular filtration rate is 180 liter per day. Whereas the urine output is only 1 to 2 liter per day, depending on the hydration state of a particular individual. So the kidney absorbs back 138 liters per day. So it has a major function in maintaining the hydration state as well as the electrolyte balances. The kidney also secretes hormones that participate in regulation of systemic and hemodynamics. We are all aware of renin, prostaglandin, and bradykinin, and most of the hypertensive states is because of the high renin production. Also, it plays a role in red cell production. The erythropoietin is produced by the renal fibroblasts. So in CKD, we see that the erythropoietin production is low and patient has renal anemia. And it also plays a part in making the 125 dihydroxy vitamin D3, which plays a part in the calcium, phosphorus, and bone metabolism. So what are the symptoms of renal dysfunction? Any person with minimal renal dysfunction do not exhibit much of symptoms. So unless we are careful, we will miss patients with renal disease. So they do not have the symptoms till advanced stages. Initially, they might have high blood pressure, but might not always be true, especially in patients with salt-losing nephropathy. They might not have a high blood pressure. Anorexia, nausea, vomiting, metallic taste, altered mental status, and associated edema. It might be seen an advanced renal failure. So most of the times the symptoms are exhibited only in CKD stage 4 or even 5. When we see in advanced stages, it's advanced signs of uremia or asterixis, pericardial rub, which is uremic pericarditis, uremic bleeding, which is because of the qualitative platelet dysfunction, which might sometimes result in hemorrhagic diathesis. So the symptoms are not usually seen in the early stages. By the time we see the symptoms, it's usually delayed. So how do we go about evaluating a patient with renal dysfunction? So somebody comes with a elevated renal function, elevated creatinine to the OPD. To how do we go about? The traditional method used by the nephrologist is the initial test done by a nephrologist will be a urine analysis. Urine analysis plays a major role in evaluation for in any kidney disease patients, because most of the time we pick up what is the abnormality by the urine itself. So the 3 parts of the urine analysis includes urine dipstick, urine microscopy, and urine protein estimation. So urine dipstick, this I have just given a pictorial representation of a urine dipstick. What all do we measure here? So if we see, there is semi-quantitative grading of what various measurements which are done using the urine dipstick. Am I audible, madam?
Yes, sir. Yes, sir.
Oh, thank you, madam. Thank you. So we have various parameters which can be measured in the urine dipstick. They include the urine pH, specific gravity, leukocytes, nitrates, protein, and so on. So when we see the urine pH, it could be acidic or basic. Where and all it could be acidic. Acidic pH is seen when there is underlying metabolic acidosis, or when the particular person consumes protein, especially animal protein. Animal protein produces a lot of acid in the blood, and the kidney has to make up for it by making up acidic urine. As well as in dehydration state, there could be acidic urine. Where do we see alkaline pH? Alkaline pH is seen mostly in the vegetarian diet. The fruits and the fruits mainly, they give alkaline pH, and then it has the bicarbonate has to be eliminated, and then the urine turns alkaline. As well as in conditions like renal tubular acidosis, we see a person with acidosis in the blood, but the urine is alkaline. That is, the kidney is not able to acidify the urine. There's a defect in acidification, like in renal tubular acidosis. So we see a person with a acidic pH and an acidic urine. We obviously we know that there is an renal tubular acidosis, acidification defect of the kidney. Then they come to the specific gravity. Why is specific gravity important? Specific gravity, to what extent the kidney can dilute or concentrate the urine. So depending on diluting or concentrating ability of, we can know, we can estimate it, we can know it from the specific gravity. So a person who is adequately hydrated or even overhydrated, the specific gravity will be on the lower side, around 1.010 or 1.005. Whereas if the particular person is dehydrated, you expect concentrated urine, wherein the specific gravity might be more than 1.020. Then the leukocytes and nitrates, we are all aware, they are increased in UTI and signify the presence of microorganism, especially the bacteria. Coming to the protein and blood, they usually signify glomerular pathology. And sugars and ketones, we are aware, they will be increased in somebody with the diabetes, and bilirubin in hyperbilirubinemia. So coming to the next part, after the urine dipstick, urine microscopy. So what are the instructions to be given for urine collections for microscopy, and how is the procedure? What is the procedure to do a urine microscopy? So before giving the container for urine microscopy, we have to advise the particular person that they should avoid physical exercise like a half marathon or a soccer match at least 72 hours preceding to the collecting urine, because they can have something called an exercise-induced proteinuria or hematuria, which might be a confounding factor there. Then we have to avoid urine analysis in menstruating women or with any genital infections, and it should be made sure that it should be collected in a clean way. So the genital area has to be obviously cleaned well, and the importance is in stressing to collect midstream urine, so that the contamination from the urethral or vaginal cells, cells from the secretion are cut down. Then how do we do a urine microscopic examination? A person with above instructions, he collects the urine and gives us in a clean container. So out of the container, we are supposed to do the urine microscopy within 2 to 3 hours, so that there is no bacterial growth and there is no, the microscopy doesn't go wrong. So out of the urine given, we take up 10 ml in a test tube, and then centrifugation of the 10 ml in the test tube is done, which is done here. It is written at 2000 RPM, but 1500 RPM is beneficial, better, because at anything revolutions more than 1500, any cast can be lysed, and you will not be able to see a cast. But if you're not looking for a cast, 2000 RPM should be okay. For 10 minutes, you centrifuge, and then the supernatant sample you discard, and then whatever the suspended particle is there, the urine, the pellet, you put it on a slide, cover it with a cover slip, and then under the microscope at mentioned magnifications, you see under a direct microscope, and then with a polarized microscope if you want to look at the lipids or crystals. So this is the way to go about collecting the sample and estimating the urine microscopy. To note is when the urine microscopy is being advised, the initial sample, first morning sample should not be advised. A second morning sample should be advised, for a simple reason that when we wake up, we do not know the amount of time urine has been static in the urinary bladder, which probably can lead to proliferation of bacteria. So second sample is supposed to be fresh. Whereas when you are doing a urine protein estimation, any sample can be taken, because in health, everything is supposed to be in a steady state. So coming to the urine microscopy, what do we look for in urine microscopy? We look at the cells, cast, and crystals. So what cells are important here? Erythrocytes, neutrophils, eosinophils. So erythrocytes are anucleate cells, which are usually isomorphic or might be dysmorphic in renal pathology, glomerular pathology. Neutrophils, we have seen already, they are increased in urinary tract infections. Eosinophils can be seen in drug-induced acute interstitial interstitial nephritis. Then renal tubular epithelial cells can be seen normally or in dehydrated states also. So here I have just given a pictorial representation of the RBCs and the RBC cast. So the RBCs, like I mentioned earlier, they are anucleate small cells which are usually isomorphic. If we see here, these are isomorphic, but you have different type of RBC called dysmorphic RBC or acanthocytes. So what are dysmorphic RBCs or acanthocytes, and what is its importance? So when we see the glomerulus, any RBC which is arising after the glomerulus will be isomorphic, but any RBC which is arising from the glomerulus, they have to pass through the glomerular base membrane and the slit diaphragm, then only come to the tubules. So when they are passing through it, their cell membrane will be distorted and can give rise to dysmorphic RBC, which can be speckled, or acanthocytes. What are acanthocytes? Acanthocytes are RBCs with blebs. I hope you can see the cursor. Blebs are there along the RBC site, RBC cell membrane. So it's also called, just colloquially, we call it Mickey Mouse RBC, Mickey Mouse with its ears. So when any person has more than 40% of dysmorphic RBC or more than 5% of acanthocytes, so that particular person is thought to have glomerular hematuria. That means he has a glomerular pathology. But whereas if a person has an isomorphic RBC and the RBC number is more than 3 to 4 per high power field, most likely the particular person might not be having a glomerular hematuria. It might be a tubular hematuria. So we have to rule out causes of the urinary tract or any stone pathology. Whereas when you are considering glomerular hematuria, you have to look for glomerular nephritis. So here we see at the right hand side, there is an RBC cast. So how is an RBC cast formed? Any cast is formed when cells are embedded into a uromodulin or Tom Haswell protein. So what is the Tom Haswell protein? It is produced by the cells of the ascending loop of Henle. So any cells which are present above the ascending loop of Henle can form cast, but cells which are present below the ascending loop of Henle cannot form cast. So the presence of cast any cast will indicate pathology above the thick ascending loop of Henle. So it could be either from the proximal tubule or from the glomerulus. So most of the time, if an RBC cast is there, it's a glomerular hematuria. So this is a hyaline cast. So where do we come across hyaline cast? Hyaline cast is nothing but concentrated urine and the Tom Haswell protein cast. That is a hyaline cast, usually seen in dehydrated state. This is a granular cast. Like I mentioned earlier, the cast can be formed only when the cells are from above the thick ascending loop. Here in granular cast, the cells are arising from the tubular epithelium, proximal tubular epithelium. So in any patients with an acute tubular injury or acute tubular injury, we have cells of the proximal tubular epithelial cells which are embedded to the uromodulin and form the granular cast. So when we see a granular cast in the urine microscopy, we are sure that there is amount of acute tubular injury happening there. So coming to the other than cells and crystals, we have seen some examples of cells and crystals in the urine. Now we are seeing the cells and cast. Now we are seeing the crystal. This is a calcium oxalate crystal. Here we can see it's a dihydrate, monohydrate, dihydrate, two varieties are there. Monohydrate is a dumbbell shape, dihydrate is an envelope shape. Likewise, all the other crystals in the urine have specified shape. This is a uric acid crystal. Uric acid crystals are usually seen in tumor lysis syndrome. If somebody has a tumor lysis syndrome, we can see uric acid crystal. Uric acid crystal, if we see, this is a polychromatic birefringence. Under polarized light, we see polychromatic, or else most of the time is given as rhomboid shape. Rhomboid shaped polychromatic crystals which are seen under polarized microscopy. So here are the various kidney lesions or syndrome with associated urine sediment. So as I mentioned earlier, pre-renal azotemia, you only get the concentrated urine. There we see hyaline cast, which are the most important things. Protein might be there and might not be there. Acute tubular injury, I've mentioned earlier, muddy brown granular cast, which are formed by the renal tubular epithelial cells. Acute interstitial nephritis, you see WBC cast as well as renal tubular cast. Nephritic syndrome, as we know the definition, hypertension with microscopic hematuria and some amount of proteinuria. So there we see dysmorphic RBCs, especially acanthocytes. There might be associated isomorphic RBCs, RBC cast, and more in the dipstick, we see significant blood as well as protein. Nephrotic syndrome, we see significant protein in the urine dipstick. Along with, in nephrotic syndrome, along with significant proteinuria, you also see lipiduria. Lipiduria, how does it manifest in the urine sediment? We see lipid droplets, oval fat bodies, or birefringent Maltese cross under the polarized microscope, as well as you also see cholesterol crystals. There again we have seen crystal nephropathy, various crystals which can be seen with the plus or minus blood, and osmotic nephropathy. When you give hyperosmotic solutions, you can see that there is insult to the renal tubular epithelial cells which might be swollen and which might be seen in the urine sediment. So this is about urine examination with the dipstick sediment. Now coming to the proteinuria estimation. So normal protein excretion in the urine is less than 150 milligram per 24 hours. Albumin accounts to mostly only 20 milligram and less. And the rest of the protein is only protein which is made after the glomerulus. So that is most of the protein which is after the glomerulus is the Tom Haswell protein. So why is it that the albumin is not excreted in the urine? As I have mentioned earlier, the creatinine has only molecular weight of 118 Daltons, whereas the albumin has a molecular weight of more than 60,000 Daltons. It's a heavy molecule and has a negative charge. So the glomerular base membrane is made in such a way that the podocytes and the slit diaphragms does not give that much amount of space for albumin to come out, as well as the glomerular, the capillaries, if you see, it is lined by negative charge, which will repel the negative charged albumin, and it does not promote albuminuria. So any excretion in the any increase in the excretion of albumin to more than 30 milligram per day, or even any excretion in the increased amount of light chain is significant. So how do we estimate proteinuria? Proteinuria can be estimated, I have shown you earlier, by a simple semi-quantitative method, that's the urine dipstick. Then there is a 24-hour urine protein estimation, and then you have a urine protein creatinine ratio. So if we remember earlier, the urine protein dipstick, we have color changes. Color changes, it's called protein error of pH. So negative to 4+. So I have just given a tabular column which might indicate what? It's just a approximate value which might indicate negative is less than 10 milligram per deciliter or less than 0.1 gram per 24 hours. So if a 4+ is indicated in the dipstick, it might most likely be more than 5 gram per 24 hours or more than 1 gram per 100 ml of urine. So it's a semi-quantitative estimation. So 24-hour, next coming to the 24-hour urine protein estimation. 24-hour urine protein estimation is considered the gold standard. Along with the 24-hour urine, when the 24-hour urine is collected, along with the protein, we also estimate creatinine. So we are supposed to estimate the creatinine so that we verify that the sample collected is appropriate. So the creatinine excretion is almost 20 to 25 or even 25 to 30 mg per kg per day in an adult female or male. So we estimated just to verify that the sample is appropriately collected for 24 hours. If it less or more, the protein estimate might increase or decrease respectively. So more than 3.5 grams of protein excretion per day is called nephrotic range, and anything below that and more than 150 milligram is called subnephrotic range of proteinuria. So next comes the urine protein creatinine ratio. So how does it offer us, how is it beneficial? It is considered inferior to 24-hour urine protein estimation, but it offers easy measurement in a single spot sample. So it is cumbersome for anybody to collect 24 hours urine. Sometimes it might warrant inpatient admission, patient might not be comfortable. So to rule out proteinuria, a spot urine protein creatinine ratio is done. Most of the time, if the spot urine protein creatinine ratio is negative, it rules out proteinuria. That means if the spot urine protein creatinine ratio is less than 0.2. Whereas if it is present, it is always worthwhile to go for a 24 hours urine protein again to have a correct estimation initially. There is a strong correlation between protein creatinine ratio in a random urine sample and 24-hour protein estimation. So at a normal renal functions, most of the time, both of them correlate, but there are some doubts which I've expressed, especially in renal failure, advanced renal failure, when the serum creatinine is high. But some people have done studies wherein to prove even at advanced renal stage, advanced renal failure, the protein creatinine ratio might correlate with the 24-hour protein serum, 24-hour protein estimation. So next in line would be imaging. So what kind of imaging can be done in evaluation of renal dysfunction? Ultrasound, contrast tomogram, MRI, nuclear scintigraphy. So what all do we look in ultrasound, and where is it, what does it delineate? Ultrasound is the initial cheapest mode of investigation which is available everywhere. In that, mainly we can see the abnormality of the renal collecting system that is grossly visible. So the size of the kidney can be noticed, any abnormality in the collecting system can be noticed, any associated agenesis or dysgenesis can be noted. And also the most important thing which has to be noted is whether there is any corticomedullary differentiation, the cortical thickness, how is the cortex looking, how is the echogenicity of the cortex. So these are the things which we are supposed to look at in the ultrasound. So coming to the contrast tomogram, where do we do the contrast tomogram? So if we are not able to delineate well in the ultrasound, a contrast tomogram is required. So mainly if there is any SOL, space occupying lesion, then we go for a CT picture so that it is well delineated. Or currently the CT is the first investigation of choice when we suspect any renal calculi. So also when you want the vascularity to look at then contrast enhanced CT also can be done. So where is MRI done? MRI is not mainly done in the renal system, but can be useful when you're suspecting renal arterial stenosis. So MRI is second to direct angiography. So direct angiography is the method of investigation, gold standard method of investigation for renal artery stenosis, but an MRI is second to a renal angiogram. So here I would just like to mention a few points that most of us are worried about the renal functions when we do a CT contrast. But during MRI, unless the patient has chronic kidney disease stage 4 or 5, it is not necessary to worry about contrast. So the contrast used in MRI is gadolinium contrast, whereas you use ionic contrast in CT, which is hyperosmolar and which can cause renal injury. Whereas in MRI, the gadolinium contrast is not per se nephrotoxic, but it can accumulate in people with advanced renal failure. What the gadolinium, it mimics calcium and it can provoke fibrosis. So you come across something called nephrogenic systemic fibrosis when a contrast is given, when the gadolinium is given in advanced renal failure. So it has to be noted that the patients with advanced renal failure, gadolinium contrast has to be avoided. Then we have the nuclear scintigraphy. So under nuclear scintigraphy, we have the DTPA scan and the DMSA scan. DTPA scan is mainly used for estimated GFR. So not the measured GFR, estimated measured GFR. Sorry, if I have made a mistake prior. Using the CKD, EPI or MDRD or the Cockcroft goals, we can only do the eGFR, that is the estimated GFR. We are estimating using the creatinine value, but here we are measuring the creatinine directly when you are doing the nuclear scintigraphy, that is by the DTPA. Whereas in the DMSA, we can delineate the kidney scars or tissue which can be there. So DTPA is a dynamic thing, DMSA is a static thing. So here I have just given some examples of the ultrasound pictures. In the left hand side, we see a normal kidney with a normal echogenic cortex. If we see and compare it with the renal hilar fat tissue, it is hypoechoic. So it is a normal kidney with normal cortex. Whereas if you see on the right hand side, the cortex is hyperechoic. It's almost gone. Probably the particular person might be having a ESRD, end-stage renal disease. So next in line would be after evaluation, after a urine routine, and then doing an imaging. If we don't reach a conclusion, or if we need further evaluation, we go with a renal biopsy. So what are the situations in which we do a renal biopsy? We do not do renal biopsy in most of the acute kidney injury, wherein we diagnose what is the reason for the acute kidney injury, and we remove the offending agent and the patient becomes fine. If suppose the patient does not improve over some time, whatever expected improvement is not there, then we can go ahead with the renal biopsy, because that is the only investigation which would tell us histologically what is happening inside. Or else if some particular person is presenting with a normal kidney and an elevated serum creatinine, even though there is no active urine sediment, we can go ahead with a renal biopsy, because we have to know what is happening inside. Or if a particular patient presents with a nephrotic or a nephritic syndrome. Here in the renal biopsy, it can be done either ultrasound guided, as in the left-sided picture, or a CT guided, as in the right-sided picture. The only thing we have to make sure is kidneys are normal size with a good cortex. So if the patient presents with an ESRD or with a high creatinine in CKD stage 4 or 5, like a kidney, like this kidney with hyperechogenic cortex, we are not supposed to attempt renal biopsy, because because of the uremic bleed, the kidney is likely to be bleed, and patient will have serious complications secondary to the bleeding. But here, if we see the cortex is still black, not much echogenicity is normal. So this kidney will not bleed, and we will be able to do a renal biopsy, get the renal tissue, and look histologically what is happening. So I've just put in an example of a renal biopsy. So how does it look? So when we do a renal biopsy, what are we looking at? We are looking mainly at 4 components. This is the glomerular component, This is the tubular component. Then in between will be the interstitial component and the vascular component. In the glomerular component, we look at the glomerular base membrane. So how is the glomerular base membrane? Is it thickened or is it thin? Then how are the cells? These are the parietal epithelial cells, and the cells lining outside the capillary are the visceral epithelial cells. Is there any proliferation in the cells? This is the mesangium. Is there any mesangial proliferation, or is there any mesangial cellular proliferation, or is there any cellular proliferation inside the capillaries? So all these things we'll look at. Also we'll look at the interstitium. What is happening to the interstitium? What is happening to the tubular epithelial cells? And what is happening to the vasculature? So all these things will be looked at, and there are various glomerular pathologies which come under the nephrotic or nephritic presentation, which will lead us to the diagnosis. So after this would be the evaluating part. Briefly, I've just put in 3 cases for discussion. The case 1, we have a 52-year-old gentleman with who is diabetic for 15 years and hypertensive for 5 years with the pedal edema for 3 years and mildly elevated renal parameters and urine protein excretion 2.5 gram per day. So if we see this presentation, most of us will see this kind of people presenting very often to our OPD. So what would be the diagnosis here? So here it is quite obvious that the diagnosis here would be a diabetic nephropathy. A few words about diabetic nephropathy. Here, if you see the picture, it is written natural history of diabetic nephropathy in type 1 diabetes mellitus. So why is it type 1 diabetes mellitus? Only in people with type 1 diabetes mellitus, we know the exact duration of onset of diabetes. So from there, we can chronologically, we can estimate what is happening to the patient. But when we most of the times, we do not know patients with type 2 diabetes from when they are having type 2 diabetes mellitus. So we are not able to exactly chronologically put in. So the natural history of a type 1 diabetes patient is extrapolated to a type 2 diabetes patient, and we think that whatever is happening in the type 1 diabetes also might happen in the type 2 diabetes also. So if we see, this is the 0 to 30 years of age, what happens, and what happens to the GFR, this is the GFR, the red line is the GFR. What happens to the blue line? Blue line is the protein excretion. As we see, as the time progresses and the duration, with the duration of increase in the diabetes, there is decreasing in GFR trend as well as increased proteinuria. It has 5 stages: stage of glomerular hyperfiltration, silent stage, incipient stage, overt nephropathy, and ESRD. Why is diabetic nephropathy important? Because diabetic nephropathy is treatable with adequate control of diabetes in the initial stage, and the most important thing being adequate control of hypertension. Even though the patient reaches stage 3 or stage 4, the progression of CKD in diabetes can be retarded. That means the slope can be retarded. If you see the slope here, the slope is very steep as the disease progresses. The slope can be plateaued so that the patient reaches ESRD somewhere after 50 years. So how do we help the particular person with long-standing diabetes? The most important thing is, after the initial phase, the adequate control of sugars does not help. A HbA1c of equal to 7 is more than sufficient, whereas the blood pressures have to be adequately controlled. The 2 drugs which have played an important role in managing diabetes mellitus are ACE-ARBs, that is ACE inhibitors or angiotensin receptor blockers. So these are 2, both of them are time-tested drugs which have to be used in patients with diabetes mellitus. With the help of ACE-ARB, we decrease the intraglomerular hypertension, thereby promoting retarding the progression of kidney disease and giving them some time, buying them time so that they don't reach ESRD. The most important drugs which have come up for the past 7-8 years are the SGLT2 inhibitors, which are the current trials, the credence trial, which has come up 2 years, almost 1.5 years prior, or the DAPA CKD trial, which has come up very recently, they have shown significantly that there is in fact retardation, or even sometimes even the microalbuminuria can be, it can normalize with the usage of SGLT2 inhibitors. So it is quite important to make sure that if we have a particular patient under our care with diabetes, the particular patient should be, if possible, on ASARB, or it would be beneficial if he can be on both ASARB as well as SGLT2 inhibitors. Word of caution here, when a particular person is on ASARB, we have to make sure that there is no decrease in the GFR. If any particular person is started on ASARB, there will be an initial decrease in the GFR, which should not persist. So if a person is started on losartan or ramipril, we have to repeat serum creatinine after a week, and any creatinine more than 1/3 of the normal baseline value is not acceptable, and we have to is hyperkalemia. So we have to make sure any person is on ASARB that they don't have a hyperkalemia. So these two are the things which we are supposed to keep in mind. So coming to the case 2, we have a 33-year-old gentleman presenting with abdominal pain and hematuria. Family history of death of father at the age of 55 due to renal failure. On examination, he has hypertension with mild renal dysfunction. Here, if we see, the particular patient is presenting at 33 years. That is at a middle age, young age, young to mid, third decade. He is presenting with abdominal pain, and he has a family history where his father has died because of some renal related illness. So it's a genetically transmitted disease which is presenting at around third decade. The first possibility here would be a autosomal dominant polycystic kidney disease. So it is a hereditary transmitted disease which is usually diagnosed in the form of hypertension. We see that there is mild increase in serum creatinine with associated hypertension, and the patient might present in his early 30s or maybe middle 30s. But with poorly controlled hypertension, we see that they progress very rapidly, especially ADPKD type 1. They present the PKD type 1 gene, they present very rapidly, reaching ESRD by 50 to 60 years of age. Whereas PKD2 gene, if they have, they reach ESRD only by 70 or 80 years, or some people might even not reach ESRD. Associated, when you palpate the abdomen, you might have palpable kidneys which are palatable in ADPKD. So coming to the case scenario 3, we have a 33-year-old gentleman who is otherwise normal, who had a history of gastroenteritis with severe dehydration, presents with azotemia, creatinine of 4, and oliguria after an intake of tablet diclofenac. So here I want to specifically stress the importance of NSAIDs. When we give any NSAID to a patient who is on, happens, there is significant drop in the GFR. So GFR is contributed mainly by the renal afferent artery, which supplies the blood. So in a person with significant dehydration, when NSAID is given, there is inhibition of prostaglandin and significant afferent arteriolar constriction, which just drops the GFR, leads to acute tubular necrosis and oliguria and a serum increase in serum creatinine, which might even go up to a stage of dialysis requiring stage. But most of the time, patient will recover within a few weeks. But with a simple avoidance of NSAIDs in any patient with dehydration, all of this can be prevented. So I want to impress upon this fact. So I would conclude my talk with this. My aim, my objective of this talk was to just enlighten and just brush up the approach to renal failure in day-to-day outpatients. I hope it was educative. So thank you very much for the opportunity given to me. Any questions you want, please, you can ask, and I would be more than happy to address them.
Any questions? Please ask it.
Sir, good evening, sir. This is Dr. Srinivasan.
Good evening, sir.
Sir, is there any? I have a question. Is there any supplements which help to improve the renal function, sir?
See, I'll just. There are some drugs called NephroSave, or I'm not aware of the names. See, they are intended to.
Okay.
The name suggests the patient would be happy if you prescribe them, but there are no magic pills to get down the renal dysfunction. So that's a fact. But there are some drugs which are put in such a way that the patient will be quite attracted. When you give them NephroSave or NephroFort, they believe probably it will make the renal function come down. But as I have told earlier, only adequate control of blood pressure and adequate treatment of the underlying disease are the only things which can prevent progression of renal dysfunction. So the answer is no. No, we do not have any magic.
Thank you.
Any other questions, please?
Good evening, sir. This is Dr. Manikandan, physician. Actually, it was an excellent presentation, starting from the basics, from the classification of CKD up to the approach and everything, sir. Actually, do you expect any drop in GFR even after starting the SGLT inhibitor, sir? Like how we start in the AC inhibitor or ARB inhibitor?
Yes,
we expect a drop in GFR in the 1.
Yes, yes, yes. What happens is, how does the ACE-ARB act? They act at the efferent level. So you have the afferent artery and the efferent artery. When you give ACE-ARB, what they cause is efferent arteriolar vasodilatation. Either the afferent artery vasoconstriction or efferent arterial vasodilatation, both will cause some amount of decrease in the GFR, which will be reflected by increase in the serum creatinine. So if any particular person has a serum creatinine of 1.3, he comes to you, he has underlying diabetes and proteinuria. We start him on ACE-ARB. Any creatinine which is more than 1/3 of 1.3, that is, that will be almost 1.6 or 1.7. Anything above that, it is a contraindication for continuation of ACE-ARB. So if we start him at 1.3, 1.4 or 1.5 may be acceptable. So anything above 1.6 or 1.7 will be a contraindication to start ACE-ARB, and they have to be stopped immediately, sir.
And do we expect the similar drop when we are starting SGLT inhibitor also, sir?
SGLT2 inhibitor, we actually, what happens is, along with the we don't expect in SGLT2 inhibitor. It acts like a diuretic initially. What happens is, the SGLT2 inhibitor, the sodium and glucose absorption in the proximal tubule is cut down. So there is more pickup of the sodium by the juxtamedullary apparatus, which has the tubuloglomerular, and then renal hyperfiltration alone comes down. If there is any hyperfiltration, it comes down. So it prevents the hyperfiltration injury. We do not expect any fall in the GFR or increase in serum creatinine with minimally there is definitely some amount of decrease in GFR with the SGLT2 also, but not in terms of ACE or ARB.
Okay. And the last question, sir, like as per your wish, like how long a physician can manage a CKD patient? Because many of my patients CKD, we manage up to the stage of CKD 5, even up to CKD stage 5, for example, because they are very well controlled. For example, they have a creatinine of 4 and they are very well controlled. I have been controlling them for more than a year or 2 years with potassium, everything, or almost normal. So when do I need to refer to a nephrologist for preparing AV fistula or something like that as a prior to this?
Yes, sir. Thank you very much for the question, sir. So what physician has to do when he sees the renal patients for a first time? So if you have established the diagnosis, he has CKD, but unfortunately CKD will not be the diagnosis. What is the diagnosis? The diagnosis is hypertensive nephropathy or diabetic nephropathy or glomerular nephritis, or it's an acute kidney injury or an ADPKD. So we have to put down the diagnosis first. If we are not able to come to a conclusion with the presentation, then it might be of help to seek a nephrologist's help. Once the diagnosis is confirmed, once you make a diagnosis, it is not necessary that a particular person has to be treated by nephrologist alone. He can be very well managed with a physician because you know the diagnosis. Unless the particular patient requires the particular treatment, even that can be managed by a physician. But coming to a diagnosis is very, very essential. If we come to a diagnosis, it's all the same. Whether a physician treats or a nephrologist treats, the medicine is going to be the same. But diagnosis is very paramount, only because when we know the diagnosis, only then we can gauge how is the progression going to be, and is it falling in line. If suppose you take a natural history of diabetes mellitus or a diabetic nephropathy, the fall in GFR is almost between 8 to 12 mils per year. So we would want to cut down that 8 to 12 mils. If a person is coming to you with a creatinine of 1.5 and within an year the creatinine has progressed to 2.2, that means we are missing somewhere. But if it is the same 1.5 or 1.6 or 1.7, so how long can we hold him? How long can we retard the progression is the most important point. If we can achieve that, whoever is treating doesn't matter. And coming to CKD stages, the final stages 4 or 5, when do we refer a patient to a nephrologist? So most of the times, if the creatinine eGFR is less than 15, immediately we have to refer, because the earlier the fistula is done, the better. The initial thought was, if the eGFR is less than 15 itself, the hemodialysis has to be started. But the current thought is to wait as long as possible. Once a fistula is made, fistula has to be made if the eGFR is less than 15. But when do we dialyze a patient? We dialyze a patient only when they are symptomatic, only when they have symptoms of uremia, or when they have hyperkalemia, acidosis, uncontrolled hypertension, or uncontrolled, unmanageable fluid overloaded stage. All these are indication for dialysis. So if the patient is in treatment in both with the physician and the nephrologist, just you can refer to a nephrologist on periodically, where he just goes and then reviews and he is under your follow-up. That is very good for the patients.
Okay. Thank you, sir. Thank you. Most of our patients are mostly diabetic nephropathy only. So that's why, sir, because I manage up to diabetic nephropathy CKD in stage 5, I refer them only when they have a sudden rise in creatinine or they have a irresistant hyperkalemia, or those things only we refer. So that's what I'm making.
Yes,
and
that should be sufficient, sir. Thank you very much.
Regarding the anemia, erythropoietin, like what is the target level of hemoglobin you suggest, sir? And erythropoietin at what time? Erythropoietin or the iron supplement? Usually we can't see ferritin because ferritin can be elevated in CKD.
Yes. So what has happened is, instead of ferritin, you also can see the transferrin saturation or total iron binding capacity. What they have suggested is a hemoglobin of up till 11 to 12. Ideal, I would prefer anything less than 11.5. So 10 to 11.5, 10.5 to 11.5 is ideal. If anything less than 10.5, it affects the quality of life. Anything more than 12.5 or 13 is detrimental to a CKD patient. Especially on hemodialysis, they have observed that anything more than 12.5 or 13 will lead to uncontrolled hypertension, clogging of the AV fistula. That means the fistula gets clotted, and there are CVA events, more CVA events with the erythropoietin when it is given beyond 13. So erythropoietin has to be started before the hemoglobin falls to less than 9, and has to be stopped once the hemoglobin reaches 12 or even 12.5. So you have to titrate accordingly, sir.
And 4,000 units subcutaneous weekly once or once weekly?
We started as 50 to 100 units per kg per week and titrate upwards or downwards depending on the response.
Okay. Thank you, sir. Thanks a lot, sir.
Any other questions? Actually, in practice, generally, when we see cases with edema, we get the basic tests done, like the urine analysis and the blood urea nitrogen. So just tell us at what levels we treat it as an emergency and refer immediately, and what level we refer as an OPD.
Yes, madam. See, the emergency would obviously be any person come with edema. Emergency, whether you refer to a nephrologist or any other specialist or you manage, emergency is when the patient is having pulmonary edema. If a patient does not have pulmonary edema, most often it is not emergency. You can have managed OPD. So if you see somebody with edema, all the things which will come to our mind usually will be whether it's a congestive cardiac failure or a liver failure or a hypothyroid or CKD. So a simple urine routine examination with edema and a significant edema should show a minimum of 3+ protein. If it shows patient has a significant edema and it shows only 1+ protein, unlikely that it could be a related to renal function. I'm not telling absolutely no. When there is a dilute urine, it might not pick up proteinuria. So if the urine specific gravity is at least 1.020 and the urine protein is only 1+ and the patient has significant edema, most likely it is not renal cause. So you will have to look for other causes. So because not necessary that only one condition has to be in a patient. As a particular patient can have all the conditions. He can have a cardiac illness, chronic kidney disease with a liver as well as hypothyroid. So we'll have to differentiate what is what and do accordingly, madam.
Any other questions? And we just like you to tell us about the team in Naruvi, your nephrology, and also the facilities for this dialysis and other things.
Yes, madam. We are having currently 10 suites for hemodialysis, madam. Basically, we give both regular hemodialysis as well as emergency-based hemodialysis. 10 specified suites are there. The rate is also nominal as much as CMC only. Other than hemodialysis, we have 5,008, that is sled machine. For ICU patients, we have low efficiency dialysis that we have, as well as we have a CRRT machine also. CRRT machine mainly is helpful in dialyzing patients who are critically ill with more than 2 inotropes. So in more than 2 inotropes where the hemodynamically unstable, the CRRT machine is useful. That's a bit costlier, but a sled machine is as the cost is as much as a regular hemodialysis machine, madam. Along with that, we have started renal biopsy services. So we are doing renal biopsy. We have an in-house renal pathologist who can give us diagnosis after the renal biopsy. We have an interventional radiologist along with us. We as a team perform renal biopsy. We have been doing it. We also have facilities to provide for CAPD insertion and care also, madam. So these would be the major things apart from the renal transplantation. So apart from renal transplantation, which would require certain amount of time to get the permission, we have all the services for renal care here.
Okay. Thank you, sir. Anyway, any other questions? So shall we conclude?
Thank you very much for the time given and the opportunity given to me, madam.
Yeah. Thank you, sir, for accepting our invitation at a short notice.
Hope you enjoyed it and it was informative.
Yeah, definitely. And thank you very much for this wonderful academic session on diagnosing renal dysfunction. And it was very informative for all of us from different streams of medicines, actually. And this will definitely help us in our clinical practice, especially when we read these blood and urine reports. And it was a very interesting session. With good academic updates also, and you have taken a lot of effort to teach us all the basics, and especially the reports, reading of the reports and what significance and everything. So it's like it was brushing up our knowledge, and thank you so much for spending time with us on a Sunday evening.
Thank you, madam.
Thank you
very much.
Thank you, sir. Thank you so much, and thank you. And now we go to the vote of thanks by Dr. Srinivasan, our treasurer.
Yes, ma'am. Good evening to all. Thank you, Dr. Krishna Chaitanya, for your excellent talk on diagnosing renal function. It was very informative, and it was very informative to all the specialty of doctors, not only any special concerned doctors. So it will be helpful for even pediatricians and other ortho or other departments also. It was very detailed presentation. Thank you for those things. And I thank all the members who have participated in this CMA program. Thank you, one and all. Kindly give your support as always. Thank you.
Thank you. Thank you, all of you. Thank you, sir.
Thank you, madam.
Thank you, madam. Thank you very much. Thank you for the opportunity.
Thank you. Hope you all enjoyed the session.
Excellent, madam. Especially the diabetic nephropathy. We learned when the hemoglobin is above 12, we should not give iron. That is a new point I learned from this session and recalled all our old memories. Thank you very much for arranging such a doctor. Thank you, sir.
Thank you.
Thank you, madam. Thank you for the feedback. Nice to join. Thank you. Thank you, sir.
Butter biscuit.
Yeah, there is the butter biscuit.
Shall we take leave, sir? Thank you. Thank you, sir. Thank you. Thank you very much.
Okay.